Hey everybody, this is the second lecture of the cervical course, and today we're going to really be covering differential diagnosis. And the differential diagnosis, I think, is most important because that's going to allow us to determine what structure or structures are involved that we're treating, also really making sure that the patient is appropriate for physical therapy. So we're going to go over this algorithm of what structure is involved. So maybe it's more of an articular structure or muscular, but ultimately it's going to allow us to determine whether or not that patient is appropriate for physical therapy. And then this part will lead us into our examination of how to actually test what sort of diagnosis that we're looking for. So similar to the anatomy and biomechanics lecture, we have a few quiz questions here. I don't expect you to know all of these because this is the stuff that we're going to talk about today. So first one, what are the Cloward's areas? Cloward's areas are areas in the cervical spine that if, let's say, someone has a cervical disc herniation, then it depends what level that disc herniation is at, but it's going to have a specific referral pattern. And these are areas that are cervical referral patterns that generally go in between the scapula, so kind of like mid-scapular pain that people present with. What is the cluster for cervical radiculopathy? This one, if you took just the national entrance exam to be a physical therapist, or especially as you are going into looking to maybe get an OCS or something, this question is very important. So the cluster for cervical radiculopathy is going to be if someone has cervical rotation less than 60 degrees to the affected side. So we need to check their cervical range of motion. If they have a positive Sperling's test, so if compression increases their symptoms. If they have a positive distraction test where distraction relieves their symptoms. And then also positive neural tension in the median nerve. So the upper limb tension test for ULTT A is the fourth criteria. So Sperling's, distraction, cervical rotation, and then positive neural tension testing. Which vertebral levels have uncinate processes? We talked about this in the anatomy and biomechanics lecture. The uncinate process is those hook-like structures in the cervical spine that help limit side bending and they guide flexion and extension. Those are present from C2 to C3 down to the C7, T1. So just know that those things are present in the cervical spine and they limit mobility, but they also have some sort of protective mechanism because they affect which direction the cervical discs can move. And then finally, which transverse foramen does the vertebral artery most commonly pass through? And the vertebral artery, as we know, is a branch of the subclavian, and it goes up mainly through the C6 transverse foramen. There is some variability there. Well, some people will say it goes through C7 or C5, but for the most part, it goes through the C6 transverse foramen. For today's lecture, we're going to be using this algorithm here that allows us to determine what potential structures could be involved when we're looking at differential diagnosis of the cervical spine. This came from DeWitt and his colleagues, and it was published in the Manual Therapy Journal in 2014. So if you plug in that reference at the bottom, you'll be able to pull that up on Google, and there's actually a nice PDF where you don't even have to go onto your online resource to find that. So what we're going to do is take it first looking at the red flags up top, and then we're going to go into some movement dysfunction stuff and go over the different treatment-based classification for the cervical spine. We're going to talk a little bit about pain mechanisms and also psychosocial factors that can limit or affect someone's clinical presentation. A different study came out by John Giles, Julie Fritz, and their colleagues in 2004 that looked at some key signs and symptoms that were associated with serious pathological neck conditions. And we're going to talk about some of these today. But when you are doing an evaluation on somebody, we need to make sure that we need to rule these things out or definitely have these in the back of our mind. So let's say upper cervical ligamentous instability. With every neck patient, no matter what, I'm going to be doing some of those tests, some upper cervical ligament testing just to make sure that everything is intact. I don't have any sort of weird signs or symptoms that would not allow me to do manual therapy. Other things that I'm looking for are cervical myelopathy, which we're going to talk about later today, different neoplastic conditions, so tumors or history of cancer, maybe present cancer that's causing their cervical pain. Those things are, if they're age greater than 50 is one of the biggest ones. So if they're over 50 years old and they're having neck pain, you need to be potentially thinking that cancer could be the cause of that person's pain. Previous history of cancer, I think, is the number one indication, where if they've had cancer before, we need to rule out that it's not a metastasis. Unexplained weight loss, constant pain, these are things, the constitutional signs and symptoms that we need to rule out to make sure that the person's appropriate for physical therapy. The upper cervical ligamentous instability, we're going to talk about that and the vertebral artery insufficiency, those two things next. But then also the final one that you need to be considering when we're talking about red flag signs and symptoms is any sort of inflammatory or systemic disease. That includes checking vitals, looking at temperature, blood pressure, their resting pulse. Potentially they have just an increased respiratory rate. So if they're, right, your normal respiratory rate should be somewhere between 12 and 20 beats per minute. So if they just have a really high respiration rate, just sitting there, you need to think that something maybe more systemic or more inflammatory from the inside out that we can't treat is going on. So if someone comes in with upper cervical ligamentous instability, and remembering back to the cervical anatomy and biomechanics lecture, that's the C0 to C2 region, is that upper cervical spine. And some potential causes of instability could be trauma, especially bigger hyperflexion injuries. If they have a history of RA, they've had prolonged corticosteroid usage, because it's going to soften some of the upper cervical ligaments. And ultimately, that's going to promote that osteoporosis, which if someone has a high level of osteoporosis, we wouldn't want to be doing cervical manipulations. Other things, more congenital things like Down syndrome. So Down syndrome, or let's say Ehlers-Danlos syndrome, where they just naturally have more ligamentous laxity. I would want to know those things, because that can create upper cervical ligamentous instability. Developmental things, and then also postural changes. So there's been some cadaver studies that have indicated that people who have a really forward head posture also had some anatomical changes at their dens and transverse ligament. So those are all things to consider when someone comes in, whether or not they could have some upper cervical ligamentous instability. For me, one thing that I want to do to rule out, especially if they come in with a traumatic mechanism of injury, is ruling out fractures in the cervical spine. So about, I think 5 years ago now, my dad and I were out water skiing, and I was driving the boat, and he's barefoot water skiing, so they're prone to, if you fall, face planting is something that's very common. And he gets back in the boat after falling, and he just reports he has this bad crick in his neck. And he said, I can barely move my neck. I have a little bit of symptoms going down into one of my fingers. He goes, but Jim, ultimately, it just really feels like I need to pop my neck right now. And in the back of my mind, with my orthopedic and manual background, I say, hey, that's exactly what I do. Maybe he just needs a manipulation. But fortunately, there are tools like the Canadian C-spine rule, which help look at fractures for the cervical spine. So I went through this in my head, and I said, okay, any high risk factors that would mandate immobilization? And one of those are age greater than 65. So my dad is in his late 50s, so that didn't apply. A dangerous mechanism. Okay, he did have a dangerous mechanism, so that, yes, any one of those, that would already warrant a C-spine or a C-spine x-ray. And then also any numbness or tingling into the extremities, and he also had that. So 2 out of 3 high-risk factors would say, hey, yes, he needs to be immobilized, and he needs to have an x-ray done to rule out fractures. If there's no high-risk mechanisms, then we can trickle down into any low-risk factors that allow for safe assessment. Those are going to be more of a simple rear-end accident, no neck pain at the scene, no midline tenderness. If that allows for safe assessment, then we're going to look to see if they have at least 45 degrees of cervical range of motion bilaterally. I didn't even check my dad's range of motion because he needed to get an x-ray, but he would not have had 45 degrees. He could barely move his neck. But either way, my dad ended up having a 2-level fracture, both anterior and posterior. And so they had to go in and do an emergency fusion procedure to make sure to stabilize his neck. The reason the Canadian C-spine rules are important is because they have a 0.994 on the sensitivity. And so that means if someone has a fracture and you do this test, then it's going to pick up it's going to pick up nearly 100% of cervical spine fractures. These are called the Canadian C-spine rules because they have socialized medicine there, and it's a very good clinical tool for picking up fractures. So I highly recommend, if you're not using these or implementing these, to use this in your clinical care to make sure that you're not missing anyone who could potentially have a cervical fracture. The other red flag issue that we need to be worrying about, and that can occur from upper cervical ligamentous instability, is going to be VBI. So the vertebral artery provides 11% of the blood flow to the brain. The VBI is tested through the vertebral artery test by placing the neck in a position that can limit blood flow through the vertebral arteries. So essentially it could lead to a TIA, or a transient ischemic attack, decreasing the amount of blood flow to the brain. So the big things that we're going to look for with VBI are 5Ds and 3Ns, so any dysphagia, so any difficulty swallowing, any dizziness, anything that is a red flag sign or symptom, essentially, because they're having decreased blood flow up to the brain. And we're going to go over those 5Ds and 3Ns more so in the examination lecture next. But knowing that we do have a test that actually is not the best test, but still understanding why it's important to look at the vertebral artery, because this is a red flag sign or symptom that someone could have more serious pathology. What's nice is that despite VBI stuff, there is still good evidence overall for safe mobilization and manipulation in the cervical spine, as long as we are doing a thorough clinical exam. So some of the research out there right now that says don't do an upper cervical manipulation because they have a higher risk for a stroke or a TIA, that is, if you're doing a proper clinical exam, your chances of injuring someone, or especially having a serious or significant pathology, significantly decreases. There's some numbers behind that right here. So somewhere between 1 in 20,000 to 1 in 10 million are going to have a serious complication from cervical manipulation if that person has mechanical neck pain. 1 to 2% will have non-serious side effects from manipulation. So that's going to be anything from like a local headache or some neck tension, but these are rarely noticed after manipulation. And patients with neck pain, headaches, and or disability have better outcomes with mobilization and manipulation compared to if you add manual therapy plus exercise compared to any sort of mobilization or manipulation by itself. So just know that manual therapy, mobilization, and manipulation is a great thing to do as long as you're doing an appropriate clinical exam. Now, something else that is more of a red flag in the cervical spine is cervical myelopathy. And that is, if you look at the picture here, we see our vertebral body, and then just behind the vertebral body is where our spinal cord lies. So if they have cervical myelopathy, that means there's going to be central cord compression. So if this is the hole for the spinal cord, then they're going to have compression on the inside of that, versus if it's foraminal compression or lateral stenosis, there's going to be compression on the outside. So it's not central stenosis, that's lateral, and that's where radiculopathy comes in. So that's how radiculopathy is different than myelopathy, which we're talking about here. So what you're going to see often is an insidious onset with a gradual increase in symptoms. Cervical spondylosis usually begins somewhere between 40 and 60, and both sexes are going to be affected equally. So this isn't really a gender-specific issue. Half of those people with cervical myelopathy, so with a central cord compression, are going to have pain in the neck, scapula area, and arms. And then most are going to have both arm and leg symptoms. With cervical myelopathy, some of the first signs that you're going to see are going to be increased knee and ankle reflexes. They may also have some spasticity, hyporeflexia, clonus, Babinski's, positive Hoffman sign. And we're going to talk about those more in the examination section too. But all of those things, especially when you think of cervical radiculopathy, you think that person is going to have a poor muscle activation. They're going to have hyporeflex. So let's say they're going to have decreased reflexes. Well, if they're having increased reflexes when you're doing your testing, it's going to be easier to rule in that they have some sort of central issue going on versus more of a lateral type stenosis. Later on, as their care goes, they may exhibit bowel and bladder dysfunction as well. So someone with a more advanced cervical myelopathy, they might also have bowel and bladder changes. Diagnosis is going to be made with presentation and physical exam. So plain radiographs are typically not helpful. We really need to get an MRI or some more advanced imaging to help rule that in, because an X-ray, the radiograph is only going to show how the bony structures are looking. An MRI is going to look at the soft tissue. It's going to show us what the spinal cord is doing. It's going to give us a lot more information. Radiographic cervical spinal cord compression and hyperintense T2 correlate well with myelopathic physical exam findings. That means that if you take an MRI, especially with a T2 weighted, so it specifically shows that the spinal cord soft tissue, then it's going to be more indicative. It's going to show really well that the person does have cervical myelopathy. There is a cluster, and this is great for us clinically. So we can use this cluster to help determine whether or not someone has cervical myelopathy. That is, if their age is greater than 45, if they have ataxia with their gait, a positive Babinski, positive Hoffman's reflex, and a positive supinator sign. The more of those tests that are positive, you can see the likelihood significantly increases of that person having cervical radiculopathy. So in my private practice, I was working with a client who always presented with cervical radiculopathy. So he never had increased reflexes or he never had any issues walking or anything like that. And I was asking him these questions. He's about 57 years old, I believe. And he said, hey, I'm starting to have these new symptoms. So over the weekend, I was going to the baseball game and I tripped over my foot twice, and it's never happened before. So I don't know why. I feel like it's weird when I'm walking. And then also, I'm just having trouble controlling my leg muscle. So he feels like when he kicks his leg out, it almost gets stuck or it locks. And then also he said, and yeah, for some reason, twice over the weekend when I'm using the restroom, twice I didn't really realize that I was going, or I had to go to the bathroom afterwards after I realized that I needed to go. So he's got some bowel and bladder issues. His age is greater than 45. Gait ataxia changes. So it was my job to do some of these other tests, like the Babinski, Hoffman's, and the inverted supinator, to see exactly what was going on. Because of his bowel and bladder symptoms, I referred him back to his doctor, but those are also just some unusual signs and symptoms. He actually had a negative on those other three, so he had 2 out of 5 positive, which is kind of on the positive likelihood ratio is a 3.3, so it's mild to moderate change or potential for cervical myelopathy. And MRI later on did show some, I believe it was moderate central canal stenosis, so he does have some cervical myelopathy, but I still treated him that day. It was, there's nothing immediate red flag where he's not even appropriate for treatment. Looking back at our algorithm from DeWitt and colleagues, the other thing that we need to rule out after red flags or keep in the back of our mind are these other biopsychosocial factors. So anything that could be causing some sort of central sensitization or anything that could be biasing our mechanical viewpoint is definitely something that we always need to keep on our radar. And that's going to be some of these yellow flag type things. So things that someone's going to have a higher pain response versus someone without some of these factors. So some of these yellow flags are going to be, let's say, a belief that pain is harmful, so they're really guarded against their pain. Let's just go down the list here. Believe that something is uncontrollable, they're not really in control of their pain at all. Let's say if they use extended rest, so someone who naturally is more prone to putting themselves on bed rest is a yellow flag. If they report extremely high pain intensity, especially that sort of pain that doesn't really match the mechanism of injury, that's going to be a yellow flag. Other things such as high alcohol or smoking, that can not only block their pain response, but that shows us that they have just different strategies for coping with pain and stress. So those are all these like yellow flags that it's not a red flag where we need to potentially refer them out. It's something that could really confound their plan of care. So we need to make sure that we're just keeping these yellow flags in check. When we talk about the biopsychosocial approach, so it's looking at biological, psychological, and sociological factors that can all lead to their pain. Things that we need to be considering are the different pain mechanisms, tissue pathology, fear avoidance, other psychosocial issues. Things that I'm always asking my clients about are if let's say they've had long-standing pain, I definitely want to know how their home situation is. So what's going on with their family? I want to know what their financial situation is like. Is it a stress for them just to get to physical therapy? When I was working at the Harris Health System for my orthopedic residency, we would see a lot of chronic pain. And what I'd find is that a lot of them were, well, not only did they didn't have a lot of money, they usually took a bus with sometimes 2 to 3 transfers to get to physical therapy. So all of a sudden, they have multiple kids that also have their own issues. Some of them would have children with special needs. So all these factors are leading up that their low back pain, their chronic low back pain is here, but they have all these factors that are getting in the way, allowing them to actually focus on their low back pain. And so that's understanding the biopsychosocial approach. This came from Quintadera, and it came out in 2012. And this, I really like this because it kind of looks at he said it's his onion's skin model for understanding pain. And so on the surface, we have pain and nociception. So the body will send nociception, the nociceptors will stimulate, and it could lead to potential pain. So it just lets the body know that there's a potential threat out there. But then other things that affect our nociception are going to be our attitudes and our belief towards that pain. So let's say someone comes in and they say, hey, I have neck pain, and also this pain is similar to what my aunt had and my dad had, and they both required surgery. And so their attitude and belief is going to say that this pain is going to be greater because of my belief and what I've seen around or others who have had similar pain. Suffering, pain escape behavior. So let's say it's some of those yellow flags, like they right away they say, I need pain medication. I drink when I have this sort of pain, or smoking is the only stress reliever that helps me take the pain away. And then social environment. And that's some of those factors that we talked about when I was at my residency. So difficulty with transportation, financial difficulties, family and financial issues, all of these things add up and they can really get in the way. So we need to peel back some of those layers before we can actually get down to the true mechanical stimulus that could be contributing to their symptoms. Also, now we're looking at more of our bread and butter. So this is the movement dysfunction thing, and we're going to look at that in relation to neurogenic pathology, articular, so is the joint affected, or the nerves, muscles, much more musculoskeletal things. That's what we enjoy to treat. To do that, the best way is to talk about the treatment-based classification for patients with neck pain. And so this is going to help us determine what structures are involved. I'm not going to go through this whole chart right now, but we are going to break these down individually. When we talk about the treatment-based classification, we really want to see if they're going to fall into more of a pain control category, exercise and conditioning, mobility, headaches, or centralization. So if they're falling into a centralization category, which we're going to talk about first, that means that likely the nerve or the nerve root is the structure that's involved. If it's more of a mobility, it's probably the joint or the articular structure that's involved. So we're going to go through each one of these. As you can see in this chart, those are the 5 classifications on the left that we just talked about. So mobility, centralization, exercise and conditioning, pain control, and headaches. What's nice is that each one of these categories, these classifications, if they meet certain criteria, they also came up with a proposed match treatment that has been shown to be effective. So if someone comes in, and this is pretty intuitive, which is great, if they come in with mobility deficits, or they meet the criteria for mobility deficits, which we'll talk about in a minute, then they say that cervical and or thoracic mobilization or manipulation will be beneficial. And then also strengthening exercises for the deep neck flexor muscles. So we need to get that person moving, and we also need to retrain their muscles in their new range of motion. That makes complete sense. Let's say they meet more of the pain control classification. We need to do some cervical spine mobilization, likely low grade, depending on how much pain they're having. So that's going to help mitigate their pain. And then also, instead of doing, let's say, deep strengthening, we're just going to be working on cervical range of motion. And what's great about this is that they can start in pain control, and then someone might move to more of a mobility, and then they might move to an exercise and conditioning. So through constant reassessment, they're going to be changing what category they fit in, and that's going to change how you treat that person. So under this movement dysfunction, the general movement dysfunction, we're going to use our treatment-based classification. And the first thing that we're going to look at is the neurogenic criteria. So using the TVC, the neurogenic criteria is going to be someone who falls into the neck pain and centralization category. So remembering nervous system pathology, well, let's use me for an example. So I had thoracic outlet syndrome on my right side, and they had to go in and they did a first rib resection. So they took out my first rib. And now occasionally, if I do a lot of lifting or if I do prolonged activity on the computer, I will get some radiating pain along this radial nerve distribution. As symptoms go down further in my hand, that's called peripheralization. What I'm trying to do is centralize my symptoms and bring it back up to the source, or bring it proximal instead of the pain shooting down distally. In the centralization category, people are going to have neck pain with radiating pain into the involved upper extremity. Lancinating pain is a word that describes radiating, or it really describes neurogenic type pain. Also, we're going to see upper extremity paresthesias, numbness, and/or weakness could be present. And they may have imaging findings such as lateral, the foraminal stenosis, or they may even have disc herniations. So before we talked about cervical myelopathy, now we're going to talk about cervical radiculopathy. With myelopathy, think back and remember what those 5 criteria for positive tests for cervical myelopathy were. So we had age greater than 45. Remember my patient that I was talking about? He was over 45, gait ataxia, and there's the other 3 ones that we're going to talk about more with our examination. And that's going to be a positive Babenzi's, positive inverted supinator sign, and then also a positive Hoffman's reflex. Those are the 5 criteria that make up cervical myelopathy, where it's central cord compression. Now we're talking about the lateral foraminal cord compression. And when we do that, we need to think about what other structures, when we're trying to diagnose cervical radiculopathy, what else could be going on. There's a whole bunch of things, and even more than this list. But with radiculopathy, it is the nerve root that's getting compressed. So we need to make sure that it's truly the nerve root versus maybe something peripheral to the nerve root. Also the rotator cuff, more non-musculoskeletal things. We could think that it's more of a herpes zoster that could be mimicking these types of symptoms. So with herpes zoster, they have band-like numbness or pain that goes across their chest. It's dermatomal in nature. We just need to make sure that it's not just the nerve root that's affected. So there's a whole bunch of things that are on our radar for cervical radiculopathy, and we'll talk more about that in a second. So with cervical radiculopathy, it's a common diagnosis based clinically on the presence of neck pain extending into the arm, accompanied by signs of nerve root compression. Typically presumed to involve narrowing of the intervertebral foramen due to inflammation and/or degenerative changes. I would link that back to people are going to come in and they say they have inflammation in their nerve roots, and usually with the radiculopathy, it's more of a chronic inflammation. So if you think about that in relation to a muscle tendonitis, it's really more of a tendinopathy or a chronic inflammation. And that's going to be the same thing for when the joint structures are involved, that it's more of this chronic inflammation versus like an active inflammation somewhere that's causing radiculopathy. So it's dysfunction of the nerve root via either compression, traction, irritation, or a lesion of some sort. That's important to know because when we talk about nerve issues, generally the nerve does not respond well if it gets a lot of compression on it. So let's say that nerve as it exits the foramen, if it gets compressed here, or let's say for some reason my side, the shoulder hangs down lower, I had surgery. So that's being traction more, it's getting pulled on more for a long time. And that's what causes my neural symptoms. Also things such as, like, let's say there's a space occupying issue there. So if someone has a tumor in the upper region, it could just be putting extra stress and irritation on that region. Usually affects people between 40 and 50 years old. And then the prevalence is about 83 in 100,000 people. Typically, they have unilateral symptoms and only one extremity is affected, unlike myelopathy where it can be bilateral or it can be arms and legs. Here is a client of mine who had cervical radiculopathy. What I like to see, well, he had basically he had decreased rotation and he had symptoms going down his left arm. So he had decreased rotation to the left. He wasn't able to extend backwards. So basically he wasn't loading into the left side of his neck. He was constantly trying to take tension off of this area. A typical presentation for cervical radiculopathy is going to be radiating pain into the corresponding dermatomal area. So he had an X-ray confirm this too, which doesn't always match the clinical presentation, but the X-ray showed C5 to C7, pretty significant foraminal stenosis. And he had symptoms really traveling down the back outer side of his arm, kind of corresponding with the radial nerve or the dermatomal roots of 5 to 7. Also neck pain. My patient here had a lot of neck pain. Myotomal muscle weakness. He didn't match as much of the myotomal weakness. He definitely had the paresthesias and numbness, shooting pain down his arm. Headaches is possible. Scapular pain, that could be due to some of those clower areas. So in addition to his stenosis, he also had some evidence of narrowing through his discs. Not that that was causing his pain, but he also met that Clowards type of pain that we talked about with the quiz. And then also changes in reflexes. This is going to be hyporeflexia. As I mentioned with my person, it shows here too, they often have symptoms with cervical extension and rotation, because if we think back to our anatomy and biomechanics lecture, extension and rotation are going to have a relative closing or narrowing of the foramina there. And if they already have some sort of compromise in that region, further compromise is going to put more stress on the nerve, and it's our job clinically to desensitize that area. They're going to have stiff and limited cervical mobility. Imaging is often used for this, for helping diagnose it. And then also, something that's very interesting, I talk about using reflexes to help rule in cervical radiculopathy. Well, if you do a biceps reflex test, it's the single best neurological screening to help diagnose cervical radiculopathy. So if someone comes in and their biceps reflex is diminished or absent, the chance of having cervical radiculopathy increases from 23%, goes up to close to 60%. That's just with that one test. So let's say you do your clinical cluster, the 4 different tests for cervical radiculopathy, which we'll talk about in a second, but then also you do a biceps reflex. All these things are adding up and increasing your likelihood of having cervical radiculopathy. Those criteria, as we talked about in the quiz, and we're going to mention again now, are going to be our upper limb tension test, positive spurling test, positive distraction, and then rotation less than 60 degrees. This cluster first came out from Rob Wayner and his colleagues in 2004. What these tests look like here, the spurling, distraction, we have in the videos below outlined how to perform all these different tests, except for the seated rotation, but it's fairly simple. You watch their active range of motion, and if it's less than 60 degrees, that is indicative that they could have cervical radiculopathy when that is clustered with all these other findings. So watch the videos below for specifics of how to perform these, but just know that they have increased sensitivity and specificity the more tests that are positive here. Another test is that you can do for cervical radiculopathy is the shoulder abduction test. You perform this with the patient seated or lying. They simply put their hand on top of their head, and a decrease of symptoms is indicative of a C5 to C6 nerve root compression. So you have them sit there, and they might even tell you, they say, hey, my symptoms feel better when I do this. Now, the video that we have below is the same thing. It is called the Cody Sign, but basically it is somewhat indicative. I'm not really sure what the evidence shows on this test, but it's just another thing that you can use to cluster your findings, that the nerve root could be the source of symptoms. So again, for this test specifically, for the shoulder abduction test, they say the C5, C6 nerve root, but just know that hand on top of the head is potentially offloading this area. It could be the nerve root that is the involved structure. So we talked about neurogenic pretty heavily. Now we're going to get into different articular sources of symptoms. With that, it's going to be our mobility deficits. So here, who falls into the neck pain and mobility deficits category? Let's say a younger patient, so their age is less than 50, they've had kind of acute neck pain, restricted cervical range of motion, segmental hypomobility. Symptoms are isolated to the neck. Referred pain may be present, but typically this is like when someone says they have neck pain, or let's say they woke up this morning and had a crick in their neck, that is our mobility deficits category. We need to get this person moving better. That's essentially what we need to do. If it is either joint or kind of bony related, what we're thinking of is the facet joints, the uncovertebral joints. And what's important about this is they have high densities of mechanoreceptors, proprioceptors, increased nociceptive function. So they're very in tune to our positional space, our vibration, pressure sense. If they get disrupted, they can cause a very localized and painful, they can cause a lot of pain, and it's going to be a very distinct type of pain. Similar to if it's a joint-related issue, they're going to have more pain in the morning. That's going to start decreasing as they move. And they're also likely going to have decreased postural strength. So maybe the pain is worse in the morning, gets better for a while, but then it kind of increases later in the day again. It's because they lack the postural strength to support them all day long. If it is if it's foraminal in nature, their symptoms, they could have some paresthesias. That is going to be more where it's joint related, but they're presenting with signs of the cervical radiculopathy that we talked about. So if it's isolated to the joint, it's going to be more of a local pain. If it's foraminal, where it's also involving the nerve or the nerve root, then we might be thinking more radiculopathy in nature. If the facet joint is the involved structure, so if it's articular in nature, it's going to have a specific referral pattern, or it may have this referral pattern. So let's say you're doing your joint mobility assessment, which Chris has great videos down in the cervical assessment, examination and assessment portion. You're doing that and you notice decreased mobility in the C5, C6 region. Their referral pattern may be this if it's facet joint related. Again, when we talk about the cloward area, is how I say it's interscapular pain. Well, if the facet joint's involved, or let's say also maybe the cervical disc is involved or irritated for whatever reason, maybe it was traumatic, maybe it's the disc is just getting irritated because of local hypomobility or local mobility deficits, then they can have a referral pattern down in between the scapula. So just know that each region can refer to different parts all the way down to the mid-thoracic region. Next category that we look at is neck pain with headaches. There's three main types of headaches. We're most effective at treating the cervicogenic ones. These are going to be unilateral in nature, generally start in the neck region, and they're going to be aggravated by neck movements. What we're going to find clinically is that they have restricted cervical range of motion, restricted segmental mobility in the upper cervical spine. We're going to go in depth on how to do segmental mobility for the upper cervical spine in a little bit. They're also going to have a positive cervical rotation lateral flexion test for C1, C2 mobility. And usually they have poor deep neck flexor motor control. What I see when I think of neck pain and headaches is that person who sits for a really long time, they're working on their computer, their head is up, it's compressing that C0 to C2 region, placing it in a constant position of extension, which if we think about the anatomy back there, there is also the greater occipital nerve is back there. We're putting compression on all of those on the suboccipital triangle, which are really important for fine-tuning and positional sense of the cervical spine. So we're just closing off that area for a long time. We're not using our deep neck flexors. Eventually something has to give, and that's where we're going to get a unilateral headache or cervicogenic neck pain and headache presentation. For the treatment-based classification, the person's obviously going to fall into the neck pain with headaches category. And there's good evidence for management of cervical manipulation, thoracic manipulations to help open up the thoracic spine, different stretching exercises, and really retraining the deep neck flexors and more of our endurance muscles to allow them to sit up straighter, doing whatever activity that they need to do. And something that I don't talk about a ton here, but we're also going to be looking at the muscles as a source of dysfunction, so the myofascial structures. Each muscle has been shown to have a certain referral pattern. So if we think that the levator is a source of problems, we might be looking down at the neck shoulder angle to posterior shoulder and the medial border of the scapula, that could be its referral pattern that could be causing neck pain. Because muscles like the levator and the upper trap, they go from the cervical spine down to the scapula to the thorax, they can both cause shoulder pathology or neck pain. So let's say your shoulder's strong, but the levator is getting pulled on in the neck. It can cause issues at the cervical spine, or it could cause issues down in the shoulder. Typically, what I find is that by treating the joints where the muscles exit from, so let's say levator C2 to C3 region, by treating C2 to 3 joint, it is going to allow that muscle to calm down, or any hypertonicity of the muscle to relax, and then you can do any sort of scapular retraining. So I always typically go to the joint or the nerve that's involved first, and usually these muscles take care of themselves. Getting close to the end here. So neck pain, also using the TBC, people can fall into the exercise and conditioning category. With this, it's going to be more long-standing neck pain, so symptoms greater than 12 weeks now. That's different, as you remember, due to the neck pain and mobility deficits, which was less than 12 weeks. So here we have neck pain greater than 12 weeks, abnormal or poor performance on the CCFT test and the deep neck flexor endurance test. And so the CCFT is using a blood pressure cuff, and it just shows your ability to control your deep neck flexors. Both of those tests are going to have a substandard performance. Also, we need to be looking at coordination, strength, and endurance deficits of the neck and upper quarter muscles, flexibility, of course, and then also for these people, since they've had pain for a long time, usually there is some sort of ergonomic insufficiency that is contributing to their symptoms on a daily basis. Let's say it's that person whose computer screen is just too high up, so all day they're just in slight upper cervical extension, or maybe they're in lower cervical flexion. Potentially also, let's say it's an office worker who's just on their phone like this all day, so they're just compressing one side of their neck, which is causing an imbalance side to side. Finally, when we look at different pain mechanisms that could be contributing to one's symptoms, from a treatment perspective, we need to get into a pain control model. So if someone fits this pain mechanism or pain control, if they present here where they're having high levels of pain or other things going on, they're probably going to present with varying degrees of motion loss, headaches. They might have emotional disturbances, cold hyperalgesia, high disability scores, or post-traumatic stress. Pain control here, if we think about that also with our, let's say, our psychosocial factors, those two are on the outside here. That is kind of like a revolving sphere of, let's say, usually people that fit into that pain mechanisms, they also need some psychosocial retraining. For the cervical spine, one of the biggest issues that we see that really requires some psychosocial retraining or giving people a better understanding of pain mechanisms is going to be when we talk about whiplash-associated disorders. We may see the term WAD, W-A-D. Here, it's going to be bony, ligament, muscle, and neurological structures and other connective tissue that may be affected depending on the direction and intensity of the force impact. Unlike some of the other things where we're dealing with an isolated tissue structure, it could be any and all of these that are contributing to any sort of secondary edema or inflammation or abnormal pain response. Mechanism of injury can include motor vehicle accidents. That's the most studied version of WADS. Sports injuries, some child abuse, blow to the head from a falling object. Most of these are a traumatic injury to the cervical spine and often to the cranium too. Most common symptom is going to be the suboccipital headache and or pain that's either constant or motion induced. So that doesn't tell us too much information other than that the person is also going to likely have some sort of headache presentation. Let's say they get in a car accident today, they may not have symptoms until like the first 48 hours after things start to settle down a little bit. They're definitely going to have some mechanical symptoms. They'll probably have some neuro symptoms, some dizziness. They could have visual disturbances or issues with hearing, so tinnitus, difficulty sleeping, jaw issues. The reason that I attribute a lot of this stuff to is, first of all, after a significant injury, their pain mechanisms have been altered. So we need to retrain how they're perceiving pain. But then also, the upper cervical region is so highly dense with various nuclei, and it's so closely associated with other structures that injury to that area can cause a whole bunch of issues that don't present like a standard clinical presentation. They're going to have acute symptoms, often lasting no longer than 2 to 3 months. Chronic symptoms then are going to last over 3 months. About 85% return to full recovery within 6 months, and then up to 50% can turn into chronic whiplash-associated disorders. And you read that statistic and you're saying, what does that mean? How is that possible? Basically, because there's so many other biopsychosocial factors contributing to whiplash-associated disorders, a great majority of these people, depending on what their situation is, it can turn into a chronic issue, and those are things beyond the realm of physical therapy. With that, if you would look at the different whiplash scales, you can see that there's a lot of other factors that will contribute to someone having whiplash type symptoms. So let's say people who often have whiplash associated disorders, they could be in a motor vehicle accident and then that turns into a litigation situation. So they have maybe some sort of secondary gain. I highly recommend, and we'll talk about this more also as we get into treatment for these in a later lecture, but understanding those different factors that could be slowing down your prognosis or that can affect your plan of care when you're working with someone who has a whiplash disorder. That is a pretty quick and dirty overview of differential diagnosis of the cervical spine, but also the treatment-based classification. We're going to take that TBC and we're going to talk about all of those different tests and how to perform those in our examination section next. But in the videos below, you'll already see different articles that we've written on cervical differential diagnosis, actual case studies that we talk about. And you'll also see an introduction to some of the special tests that we're also going to recover again in our cervical exam. So thanks for following, and we'll see you on the next video.